Okay, so I think most people are probably here now. So Emmeline, whenever you're ready, you can get started.
Perfect. So I'll just share my screen. You just need to disable me to share my screen. To enable me, I mean.
Should be able to now.
I'll try again. Yeah, perfect. All right. So good morning, everyone. For those who does not know me, my name is Emmeline. I'm one of the CCFP EM in the Emerge program. So this morning, I'm going to present you my critical appraisal, and it's going to be on COVID-19 and steroids. And the reason I chose this topic, I think it's pretty obvious. It's a pretty hot topic these days, and a lot of literature on it, despite the fact that we're in the pandemic for 7 months. So it's pretty recent. So as you know, COVID-19 emerged in China late 2019. It's a zoonotic source, meaning that it can infect animals and can spread to humans. It's an RNA virus, the family of the coronavirus. And the spectrum of the disease, as you know, it can go from totally asymptomatic to severe hypoxic rest failure and even death. So I'll talk a little bit about the pathophysiology of COVID-19. Since this is important, if you want to look for treatments, you need to target a little bit how the virus works. So you need to understand it to develop some treatments, basically. So it starts with an exposure to COVID-19. So it can be by droplets, airborne surfaces. And then what happens is that the virus has proteins on it, and it adheres to your ACE2 receptors in the body. And the ACE2 receptors are not only in the lungs. So we can find them in the lungs on the pneumocytes, but also in the vasculature, the kidneys, the heart, and the GI tract. And this is why people infected with COVID-19, they can have pulmonary symptoms, but they can also present with gastro-like symptoms, myocarditis, AKI, and even thrombosis. And then the virus will enter the cells and will replicate, and the process will go so on and so on. So this is a nice graph that is from EMCrit that explain what we can resume as 3 stages of COVID-19 infection. So stage 1, it's the really early phase of infection, and this is mainly, what happens in this stage is mainly the viral replication. Yes, your body will have an immune response and an inflammatory response, but usually the symptoms will be pretty mild while the virus replicates and your body is trying to fight the infection. And what happens is that when you enter stage 2 and stage 3, you need to understand that this is a spectrum. Not everyone will pass from stage 2 to stage 3, obviously. But when you are in these stages, the problem is not really the viral replication, because actually the viral load will go lower in these stages. It's really the immune reaction of your body and the inflammatory reaction that will make you sick. So when that happens, especially if you go late in stage 2 and if you enter the stage 3, you have so much an inflammation in your body that you can have capillary leak in your lungs that creates ARDS. Your alveoli can be full of pus that will cause VQ mismatch. You can have endothelial invasion and endotheliitis that can cause vascular injury and thrombosis, and that will lead eventually to multi-organ failure. So if we go to our graph, again, it's important to understand, because if you're going to target a treatment early in the disease, in theory, you should target a treatment that's going to attack the viral replication, so an antiviral. If you're going to give a treatment that it's later in the disease, stage 2, stage 3, you're going to use more something that it's immunosuppressing, such as corticosteroids. And this is why, if you look in the bottom of the graph, the corticosteroids are more towards stage 2 and stage 3, because this is really the reaction you want to target rather than target the viral load itself. So it's a new disease. It's been 7 months. There's a lot of literature. But outside of the supportive treatment, despite that a lot of medication have been studied, except for steroids, no treatment so far has proven to decrease mortality again, except the steroids. And even so, you will see with my literature review and my presentation that we do have a strong study, but that's pretty much what we have. And if there is one medication I think we would love to work, it's the steroids. Why? Because we know this drug, we use it for so many things, is broadly available, and it's a cheap drug. So that would be a great drug to work for COVID. So that being said, my PICO question was, in patients with a positive diagnosis of COVID, does adding steroids to the standard therapy when compared to standard therapy alone lead to increased survival to discharge? So with that, I did my literature search on PubMed. I just showed it to you to, just to show you that I went broad, I used a mesh. And surprisingly, I thought, because it's a very, COVID is not so old, I thought I would have just a few articles. But surprisingly, with these two terms, I had more than 1,000 articles that went out. Obviously, when I read the titles and then some few abstracts, I had 24 that really were targeting the question that I was asking. But I think it's worth mentioning because it's pretty impressive how much literature has been made so far on COVID-19. So with that literature review, I found that the WHO updates their clinical guidance for the steroids recommendation in COVID recently. So they do recommend the use of corticosteroid with severe and critical COVID-19, but they do not recommend the use of corticosteroids in non-severe or mild disease. Same as the recommendation of INES for the Quebec, it's the same. So they do recommend steroids if your patient is moderate or severe disease or on oxygen, but they do not recommend the use of steroids if the patient is not on oxygen. But these are guidelines, and I need to explain to you how they came up with this, is that these guidelines were formed with some meta-analysis, again, very recent. Everything has been done super recent. And these meta-analyses are done based on very recent RCTs. And in these RCTs, when you look at them, they use some RCTs that, first of all, some of them were not even peer approved yet. So they use the result without these studies being peer approved. And there are 3 large studies also that studied COVID-19 with steroids versus no steroids, like just to name them, the REMAP-CAP trial, the CODEX, and the Cape COVID trial. These were included in the meta-analysis, but these studies were actually stopped early because of the study recovery published their results. And because the results were positive, it's not ethical anymore to do a study like, if you want, like a placebo and steroids. So they had to stop early. So I just want to explain to you that, in summary, these guidelines based on meta-analysis, based on RCT, I basically based on the RCT I'm going to present today. So I'm going to present dexamethasone in hospitalized patients with COVID-19, the preliminary report that has been published in July in the New England Journal of Medicine. It's part of the recovery trial. It's a critical appraisal project, so I'm going to criticize the article at the end. But I have to tell you that this is a very complicated study. And if I do not pass through it like a journal club, it's not possible for us to understand the critical appraisal. And I think then we will lose the purpose of this presentation. So I'm going to start. So this study has been made in the UK. In the UK, the mortality rate of hospitalized patients diagnosed with COVID-19 is around 26%, and it goes up to 37% for patients needing invasive mechanical ventilation. So again, they point out that a lot of pharmacological treatment has been tested, but no one so far has been proven to show reduced mortality. And they, again, like a bit I was talking earlier in the presentation, the host immune response in COVID-19 is thought to play a significant role in organ failure. Therefore, steroids, in theory, make sense to use, especially not at the beginning of the disease. So their objective for the primary outcome were all-cause mortality within 28 days after randomization. This is their short-term outcome, and we are awaiting for the long-term outcome at 6 months to come. And they did have secondary outcomes that are mentioned there. I'll skip through them because it's not that pertinent for the presentation right now. So I did a graph for you to understand the method, because again, it's not a straightforward study. The recovery trial is actually an immense study that include 5 arms, and they're going to even add an arm later. So if you see on the right side of the screen, These are the arms of the recovery trial. In the recovery trial, because there's different arms, they published the study that I'm presenting today, the arm of dexamethasone, but it's only one arm. It's not the whole recovery trial. A lot of people were eligible, like more than 11,000 were eligible for the study. And this is because they really enroll a lot of patients. And the inclusion criteria were basically you needed to be hospitalized, no matter what your age it is. You need to have a suspect or confirmed COVID-19 infection. And you could not have any frank indication or frank contraindication for one of the treatment there. If you did have, for example, for the dexamethasone, there's no way we can give it to you or we need to give to you the drug, then you were simply removed from this arm and randomized in the other arms. Later on, they added another arm, convalescent plasma versus control, and I'll tell you how they did that because of how they, the design of their study. And then later on, they decided to add another arm. So because tocilizumab, it has shown some potential. So what they did is that all the arms, including the dexamethasone arm, so the arm that I'm talking in this paper in particular, if there were any deterioration, meaning that the patient become more hypoxic or more inflammatory, they would re-randomize the patient to tocilizumab versus control. So kind of two randomization. And the little red, green dots here, it's because the arms are still ongoing. The other ones, they're done. So again, the study was done in the UK and included 176 hospitals. And it was a randomized trial, open label, meaning that the physician and the patient knew what they were receiving, but it was not open label, so it was blinded to the people who were analyzing the data. The randomization was done by a centralized website, and in the dexamethasone arm, it was separated in 2-to-1 ratio, so 2 receiving the control and 1 receiving the dex. When I say the control, it's the standard treatment that I'm going to talk later, but it's basically the most appropriate treatment without the dex. The randomization was done per hospital, not within each hospital. So it was a platform study. And you know, when I said that they added an arm, that's what a platform study is. It's a randomized study that you can be flexible with. You can add arms as it goes. And it makes sense. And you need to do this type of study in a pandemic where you're studying a disease that it's very new. Because the problem is if you start with your study with just like dex versus no dex, for example, and then they found another revolutionary treatment outside in another study, you're done. You know, you need to stop your study. But when you do a plateau study, you can actually add an arm. So that's why they did that. So these are the arm that I'm showing to you. So what you need to understand, it's usual care. Usual care, it's basically a conservative treatment with anything plus anything that the treating physician thought would work, basically. Remember that we don't have standard care yet for COVID-19. And then you were randomized basically or to an antiviral treatment or immune system treatment. And the current presentation is on dexamethasone. So again, I mentioned the inclusion criteria. So lots of people, actually 15% of the patient hospitalized in the UK for COVID got involved in the study, which is a lot of people. And the exclusion criteria, again, if the treating physician thought that or you were too sick to enter the study, or judged that you could not or had to receive one of the treatment in the arms, you were excluded of that arm. I have to mention that it's not very clear of the criteria of the physician. That was left at their discretion. So we don't know really what they meant by they felt that the patient was too sick, for example. So in the results, so I'll point out the important thing for you to understand. Again, the 11,000 patients, that was the patient that were eligible for the whole recovery study. Some of them were simply excluded they just could not receive the dexamethasone. The other ones could be randomized to other arms. And what they did is that they look at how many could enter the dexamethasone arm. And they kind of calculate their power a bit late, and then they realized that they needed 2,000 patients in the dexamethasone arm, no more than that, to have enough power to see a significant difference in the two groups. So what they did is that out of the 9,000 that could have entered the dex arm, they took a bunch of them and they said, we're going to put them in the other arms. I want to point out, this is the dexamethasone arm. This is a non-dex arm. In the dex arm, 95% of patients did receive dex. In the non-dex arm, 8% of patients did receive dex too. Remember, the non-dex arm is the usual care. The usual care is not clear. We don't have a standard of care. This is why. Same applies to the other treatment in both arms. If you see, both arms receive other medication that are being studied or has been studied for COVID-19. So both of these arms receive these treatments. However, if you look at the little percentage here, I hope you can see it's equal in both groups. And if you go down there, then some of the patients went to the second randomization that I explained earlier. So these are the baseline characteristics. I'll just mention that it's pretty, it's well equilibrated in the two groups. I did not pick up personally that the age difference was significant, meaning, I mean, not significant because it's randomized, but that it was different. But in all the podcasts I read about and the critiques I read about the study, they do mention that the non-dex arm, so the usual care arm, were a bit younger. Because it's a very important prognostic factor, the age, so they didn't mention it, and they make it seem like it was a big deal. But the rest are equilibrated. So now for the results. So for the primary outcome, so the mortality at 28 days was significantly lower in the DEX group versus the usual care group with an NNT of 36. I'll explain these numbers later. In the dexamethasone group, so that is all the study, okay? The whole DEX, the DEX versus usual care whole study. If you look at the DEX usual care versus dexamethasone in the patient who received mechanical ventilation, you see that there's a difference, but it's much higher. So 29% of mortality in the DEX group versus 41% in the usual care with a number needed to treat of 8. So you can see that it's like if the sicker you are, the more you're going to benefit from the DEX. And if you compare the DEX group with the usual care group, the mortality is lower again in patients receiving some oxygen. So 23% versus 26% with a number needed to treat of 34. However, if you look at the patient, again, DEX versus usual care, but the patient who are not receiving any oxygen, so kind of like the healthier one, there was no difference in the two groups, whether you receive DEX or not. These are subgroup analysis. Again, remember, subgroup analysis is just to generate hypothesis, okay? It's not like a strong conclusion, but I wanted to show to you that for the days of symptoms, the days onset of symptoms, and when you receive the DEX, it seems like the longest you had your symptoms, so more than 7 days, you would benefit more of receiving the DEX versus if you were more early in the disease. And it makes a lot of sense with what I showed you at the beginning of the presentation. In the early phase, it's not that much the inflammatory reaction that it's the problem, but it's the viral replication. So that makes sense. If you look again at the results, these are basically the results I just present in numbers. I want you to look at this group, so the no oxygen group. So it's actually interesting because I said, you know, there was no difference statistically significant if you were not on oxygen, whether you received the DEX or you received the usual care. But you can see that there's actually a trend towards an increase in mortality in the group that received DEX in these patients. So the healthy ones, basically, the healthy ones with COVID. So they did analyze secondary outcomes as well. There's still ongoing analysis because it's primarily report. I just want to point out that when they said, you know, the mortality is lower in the DEX group versus the usual care group, we can want to think, yes, but is that the mortality, meaning the mortality is lower, but they're more on ventilator, for example. So that's not good either, right? You want a mortality benefit, but also like a kind of like healthy benefit. So among patients who were initially not on mechanical ventilation, the rate of progression to mechanical ventilation or death was lower in the DEX group versus the usual treatment group. So that's good, meaning that it's not just a mortality benefit. It seems towards that it's a usual, they do better in general, at least the one who were not on oxygen. So now for the appraisal. So now that the study has been, I think I went through enough details. So the appraisal is actually very easy once you understand the study. So what did the study ask? It was all the patients were all the hospitalized patients with suspect or confirmed COVID-19. The intervention was DEX 6 milligram IV or PO daily for 10 days. The medium length was 7 days. And just to give you an idea, DEX 6 milligrams is prednisone 40 milligrams. Comparison was usual care. Again, what is the usual care? We don't know yet. And the outcome was all-cause mortality at 28 days after randomization. Were the assigned patient randomized? Yes, again, it was computer web-based system did the randomization. Again, the randomization was per hospital, meaning there's a hospital is DEX versus usual care, another hospital was like azithro versus usual care. There's 176 hospitals involved, so I don't think that really caused the bias because there's so many hospitals involved. So I think it diluted the result in the end. Were the groups similar from the start? Yes, again, except for age. Again, I did not really pick up on that because there's like 1.5 year of difference, but the age is an important prognostic factor. And in fact, in one of the slides I present to you with the time of DEX, when the time of the symptoms when they receive the DEX, just a bit higher in the table, there was something about if you're less than 70, you have more chances of having a good outcome, so having less mortality. So again, generates a hypothesis. It's not a clear-cut conclusion because that's not the primary endpoint of the study, but yeah, age is a big deal. So they had a little big differences. So the control group was younger. With a control group that is younger and with a study that has positive result, it's not that a big deal. Because again, if something, it should have neutralized the result or make them negative for the DEX. So aside from the allocate treatment, were the two groups treated equally? They were, except with all the other drugs that were involved in the two other groups, remdesivir, lopinavir, ritonavir, etc. But again, it was pretty equilibrated in the two groups. So I don't think it did impact that much the results. Were all the patients who entered the trial accounted for, and were the analyses in the groups to which they were they analyzed in the groups to which they were randomized? Absolutely, it was an intention to treat analysis. In my comments, simply, I will not re-explain to you what I did explain to you at the beginning, but this is how they started with 11,000 patients and they end up randomizing 6,425 in the DEX versus usual care group. An important point, however, the follow-up was 99.9% at 28 days, so almost perfect. The follow-up was done by phone if the patient was discharged to see how the patient goes, but almost complete follow-up. Were measured objectives or were patients in clinical kept blind to which treatment was being received? No, it was an open label. However, it mattered less in the fact that in that case specifically because the outcome is death, so it's a very objective outcome. But keep in mind that it still matters a little bit because as a treating physician, will you change your care for the patient who received the DEX, meaning you so want the DEX to work that subconsciously, will you change your treatment? This is always possible when it's an open label. But again, with an outcome of mortality, I think it did not affect that much for that study in particular. So how large were the treatment effect? Okay, a lot of numbers, and I will just point out what's important here. So we have the relative risk, okay, that I mentioned. So I'll start with the dexamethasone versus control group, all participants. If I just tell you, so when you look at absolute risk reduction and relative risk reduction, the only important point I need to mention, and I'll use some more easy numbers to understand, is that, for example, if in the dexamethasone group, the mortality would have been 3%, and in the control group, 4%. You would have said that the relative risk reduction in mortality is 25%. And that number looks amazing. However, you need to look always at the absolute number, because when you have small numbers, the absolute number might be much less impressive. So in my example, it would have been only 1% of absolute risk reduction. You have chance, 4% mortality versus 3%. Looks a bit less good than a 25% risk reduction. So this is, what I want to understand, because otherwise, these are just numbers, and relative risk reduction of 11%, sure, and absolute risk reduction of 2.8% is still good numbers, but the number needed to treat of 36, what does that mean? Is that you need to treat 36 patients with COVID-19 that are hospitalized with dexamethasone 6 milligram PO or IV times 7 days, which is the median time, to save one life. And then the question is, okay, but 36, is that a good number? The answer is that it depends. It depends because you need to see if you're harming your patient. What is the harm of giving the dex? We do not have in this study, unfortunately, it's too early. We do not have the consequence, the side effects of dex. So we don't know. So if you have a treatment that harms a lot of people, or it's dangerous to give, and you have one of 36, the NNT, of 36, maybe 36 is a too high number and you want lower number. So this is how you interpret the number needed to treat. But if you see, so the dex versus control in the mechanical invasive ventilation, they had an absolute risk reduction of 12.2% with a relative risk reduction of 30%, and them a number to treat of only 8. Again, you need to treat 8 patients with dex for 7 days to save a life, according to the study. So yeah, that's good. Especially we know the steroids and we know the consequences, the side effects of the steroids, and it's not that a bad drug as that. And again, I did it again for the control group versus the dexamethasone on people who were on oxygen only. So they had, an absolute risk reduction of 2.9% with a relative risk reduction of 11, and then they had a number needed to treat of 34. So the argument of using dex, it's basically the force of the trial, because again, this trial is basically the only really robust one we have, is the biggest one, the largest one. So the one that we can draw the most conclusion. Some other trials, they tend with the same result, however, I need to mention. So large trial, a lot of inclusion criteria, all ages. It represents very well the population of the UK, since 15% of the hospitalized patients were actually included in the study. And it's actually a very robust methodology, a quite complicated trial to understand, but at the end of the day, it's a really good study. And it's a drug that we know already. We know dexamethasone, what happens if you get too much too long. So that goes for pro-dexamethasone in that context. But the argument against the use of dex is that honestly, we don't know the exact dose. My other slide, I'm gonna just talk a little bit about the dose, but we don't know. They use 6, some trials use 20. So we don't know the exact dose yet. We don't know when exactly we should give it. I mean, yes, it seems to be better if we give it after 7 days of symptoms, but we don't know, there's not a specific time to give it. And again, we don't know the side effects. Does this patient have more, for example, co-infection after, more pneumonia, or, things like that. So again, we don't have the long-term outcomes. So that goes a little bit, I'm not saying against, because it's a really good study and it's actually already implemented in the guidelines, but just to remain as with the most of rester skeptic and critical. So just a tiny comment on the adequate dose. So they did use dex 6 milligram, which is considered as a low dose, like prednisone 40. But some study, like the DEXA-COVID study, that I checked on it, and actually now the recruitment is suspended, but they did study patients with COVID-19 with severe, they're all ventilated, they're all severe, and they did use a higher dose of dex. We're talking about 20 milligram IV for 5 days, and then tapping the dose. And this is based because there's actually a study in the Lancet who came out in last March, and they studied ARDS, moderate to severe ARDS, with large dose of steroids, and the early administration of dex had a reduced for mechanical ventilation and overall mortality. This is why they used big dose. But again, we don't know if, the 6 milligrams seems to work. And in any drugs, we want the lowest dose effective, because we want to avoid the side effects. But that was just a little comment on that. And, that's the MUHC guideline. So dexamethasone are actually in the MUHC guideline. So if you have a moderate or severe disease, meaning that if you are on oxygen, you should receive dexamethasone. My point of view on all that, I think that you know, if you're very severe, if you have a severe COVID, you're on a lot of oxygen or you're intubated, absolutely dexamethasone all the way. If you just have like a sore throat, of course, and you're not on oxygen, of course, no dexamethasone. These are very clear. When I did this appraisal, I was just wondering, I think that the hardest patients are the ones who are very gray in the gray zone, meaning, you know, new onset of symptoms, maybe like 3-4 days of symptoms, on a touch of oxygen. You know, am I going to arm the patient by giving him dex, knowing that the healthiest patient, they actually seem to do worse with the dexamethasone? So I think it's more these patients that I think it's okay to stay a bit skeptical and still to have a bit of criticism concerning the dex when it's not clear cut so clear. So that's the MUHC protocol, and MUHC is actually involved in the Solidarity trial, who's also looking at remdesivir in the mild COVID-19 patient, the mild presentation. So these are my references, and thank you so much for listening. I hope you found it interesting.
Thank you, Emmeline. That was really good. Let me see if we have